abnormalities within the peripheral nervous system or lower motor neuron system, the neuromuscular junction area or muscular abnormality will result in term known as neuromuscular disorder. The motor unit has two components. Motor neuron on anterior the spinal cord. Axis is other axis on the distal nerve, the neuromuscular junction disorder, the myopathy, and the motor unit is caused by suprasegmental or upper motor neuron. Classification of neuromuscular diseases. They are classified into muscular dystrophy, congenital and metabolic myopathy, anterior bone disorder, neuromuscular junction disease. So this is the same picture. The brainstem or upper motor is usually not involved in neuromuscular disorders. They are at either congenital muscular dystrophy, congenital and metabolic myopathy, interior bone cell disorder, or neuromuscular junction diseases. The etiology of neuromuscular diseases, you can see the congenital one, the muscular dystrophy, Duchenne type. This is very common among all neuromuscular disorders, followed by the hereditary neuropathies and Becker's muscular dystrophy. And then the facioscapular scapulohumeral dystrophy. These are the most common. The rest, they are very rare anomalies. How they will present the patients having neuromuscular disorder? They will be having weakness, poor cough, retained airway secretion, inability to lift extremities against gravity, muscular wasting, low muscle tone, which is also called hypotonia, poor feeding, swallowing dysfunction, failure to thrive, increased respiratory uh, rate, use of accessory muscles of respiration, recurrent infection, and night sweat. How clinical manifestation will help us in approaching a patient neuromuscular disorder, how it will narrow our diagnosis. Weakness results either from upper motor neuron lesion in the cerebral cortex causing increased breast reflex and extensive plantar responses. Lower motor neuron lesion causing hypotonia, depressed reflex, and flexor plantar responses. So if they're upper, you can say this is actually cerebral palsy or cervical or thoracic, higher thoracic lesions. They will result in uh, increased reflexes, Babinski sign, Hoffman sign, and upgoing with flow. That is the plantar, extensor plantar response. So this is clear cut indicating a problem within the brain or upper spinal cord. Lower motor neuron lesion which causes hypotonia, depressed reflexes and flexor responses. There also common like in polio. So, lower motor neuron therapy. Tone and strength should not be confused. Passive tone is a range of motion around a joint. Active tone is physiological resistance to movement. So, involvement of the face, tongue, palate, and extraocular muscle provide an important distinction in the differential diagnosis. How we will discuss it later on. Prenatal history, acute flaccid paralysis, which is, as we said, anterior horn damaged by poliovirus. It is a common sign of neuromuscular disorder. Now, come to the causes of hypotonia. Central hypotonia-chromosome disorder, static and hyperactivity reflexes, peripheral hypotonia, distal weakness and aging, neuromuscular junctions resulting in hypotonia, like myasthenia, leads to fluctuating weaknesses. At times, there will be a normal tone within the limbs and face and everywhere. At times, there will be hypotonia, muscular dystrophy. Proximal weakness will be more pronounced. Anterior horns and spinal muscular atrophy associated with wasting and hyporeflexes. Neurometabolic conditions like deficiencies, vitamin B12 deficiencies, calcium deficiency, etc. Newborn with hypotonia will be somewhat like this. You will grab his hand, pull it up. You will not be able to hold his neck straight up. Usually, normal child, they will flex their head in attempt to raise up of the bed, and at the same time, their legs will also will uh, flex. Their thighs will flex onto the abdomen. What tests do we perform to confirm or diagnosis or exclude or diagnosis of neuromuscular disorder? The different enzymes involved, like CPK, MM for skeletal muscle disease, MB for cardiac muscle, BB for brain, mainly elevated in Duchenne muscular dystrophy. The molecular genetic marker has to be checked. Nerve conduction velocity should be checked. Electromyography, again, insertion of a needle into belly of muscle and recording electrical potential in various states of contraction. Imaging of muscle and confirmation is of course by muscle biopsy, most important, vastus lateralis example. ECG to look for cardiac muscle involvement in particular disease process. Classification. Anterior consult disorders, they are classified as infectious causes which results in poliomyelitis, motor neuron diseases like amyotrophic lateral sclerosis, spinal muscular atrophy. Let's talk about spinal muscular atrophy. This is autosomal recessive disease. This is also known as type 1 Wartney movement disease, which presents with profound hypotonia and areflexia, respiratory weakness, poor swallowing, and tongue articulation. Children never learn to sit, and aspiration pneumonia cause is the cause of death in these children. Type 2, this is also called Djokovic's disease, onset at 6 to 18 months. So if you type 1 is more serious and type 2 is a bit late, uh, lately starting disease and usually able to sit unaided. but may develop kyphoscoliosis or tremors. Type 3 spinal muscular dystrophy. This is also called Kugelberg-Wallander disease. Onset is more than 18 months and usually able to walk. Treatment is supportive and respiratory care, management of feeding and swallowing, and provide adequate nutrition. So this is a bit least uh, lethal form of spinal muscular dystrophy. The first one is the most serious one called type 2 is the next regarding seriously, and type 3 is relatively uh, mild spinal symptoms. Now, peripheral neuropathy, again neuromuscular disorder. What happens in peripheral neuropathy? The peripheral nervous system is involved. The Guillain-Barré syndrome is the most common clinical pattern to a demyelinating process, including presence of local areflexia, moderate to severe muscle weakness, with motor symptoms, hypertrophy of nerves. So let's talk about Guillain-Barré or GBS syndrome, which is common cause of acute flaccid paralysis. The second most common cause is polio. This is an immune-mediated, rapidly progressive, predominantly motor matrix polyradiculopathy. Condition may occur at any age within 6 weeks prior to symptoms. Clinically, the respiratory illness and weakness 2 weeks to 4 weeks after onset, along with tachycardia, arrhythmia, bladder dysfunction, labile blood pressure, and impaired thermoregulation. How do you diagnose it? Uh, Diagnosis is of course clinical, and the second, which we come across these patients in neurosurgery as well, with GBS, the uh, the typical presentation of the patient is ascending neuropathy. The weakness or neurological deficit starts at the periphery, especially in the lower leg, starting from the toes, then the ankle, then the knee, then the hip, and then even abdominal muscle and the upper limbs are involved in delayed presentation. So this is also called ascending neuropathy. The treatment of uh, this GBS, the islet, plasmapheresis. Plasmapheresis is separation of the immunoglobulins within the blood, within the serum, which affects the nervous system, should be extracted from the serum of the patient. And the second, immunoglobulin G at 2 milligram per kg dose for 2 to 5 days. Or plasma exchange in children presented in 2 to 4 weeks. Those who present within 2 to 4 days, if it is chronic, it is not effective. The load of plasma immunoglobulin G will be less. Do not respond. Do not respond. Give second thought. If it do not respond with 2 to 5 days immunoglobulin G course, you have to refuse the course. And general supportive care. If he is, of course, physiotherapy to prevent bad sores, he is unable to sit or move his limbs. So you have to prevent the bad sores, provide adequate physiotherapy, and of course, lung secretion, lung physiotherapy. And then if he is developing diaphragmatic involvement and having breathing problems, you have to start it respiratory supportive support should be given, including intubation of such patients. Then third, respiratory care and nutrition management. Myasthenia gravis. This is the disorder which involves the neuromuscular junction, or it is usually autoimmune and autosomal recessive trait disorder characterized by rapid fatigability of creatine muscle. Three clinical variants: juvenile in late infancy and childhood, showing extraocular muscle weakness; congenital, transient nutrition symptom arises after birth till third day, occasionally associated with hypothyroidism, systemic lupus erythematosus. What happens in this disorder? There are acetylcholine receptor antibodies and they might be positive. Electromyography shows increases jitter or blockage. Show increases jitter or blockage. Muscle will having intermittent neural activity. Diagnostic tests done by hydroconium chloride 0.1 to 0.2 milligram and effects of weakness as distance between upper and lower leg is within 10 seconds. This is given IV bolus. You know what happens in Myasthenia Gravis? You ask the patient and patient sitting in a wheelchair, you ask the patient without moving her head, just move eyelid and eyes upward towards the ceiling. Patient will develop fatigue, his eyes will start closing. That is ptosis will occur. If you give at that stage metroponia, the patient weakness will disappear. So this is a kind of diagnostic and diagnostic test and confirmation of Myasthenia Gravis. Myasthenia Gravis require no treatment. Debilitating conditions should be treated with cholinesterase inhibiting drugs such as neostigmine, pyroxychine, prednisolone in case of autoimmune causes of destruction of uh, acetylcholinesterase receptor. Thymectomy or plasmapheresis with immunoglobulin G is effective in high circulated levels of anti-acetylcholine receptor antibodies. Thymectomy, where these antibodies are produced in thymus. So removing that will alleviate these excessive antibodies produced within the thymus. Plasmapheresis to remove this excessive antibodies and this immunoglobulin G therapy. Muscular dystrophy, a group of genetically determined progressive primary myopathy characterized by degeneration and death of muscle fibers occurring at some stage of the disorder. So, muscular dystrophy means the muscles which were initially formed, they will degrade, degenerate. There will be few live or active functioning muscle left within the uh, single muscle. I mean, the fibers, all of them might not be degraded or degenerated. Some of them will still be there, and that is the source of minimal residual function at that particular muscle. Muscular dystrophies are classified as Duchenne muscular dystrophy. This is congenital one. Becker's again, muscular congenital one. Myotonic muscular dystrophy, congenital muscular dystrophy, glycogenosis, mitochondrial damages within at genetic level, distal muscular dystrophy, like polymyositis. These are acquired ones, these are not congenital. The upper ones, which were congenital ones. Dermatomyositis, polymyositis, inclusion body myositis. Let's talk about Duchenne muscular dystrophy. This is X-linked recessive disorder, absence of the dystrophin protein within the muscle, slow to reach motor milestones. Symptoms appear in the second year or second 2 to 6 year period when the symptoms will start with clumsy walking or falling on walking or running or and uneven ground. Muscles replaced by fat may appear hypertrophic. So there will be false muscle hypertrophy. Don't take them as bodybuilders. There might be a bodybuilder appearing child having very thick muscular projection might be only fatty replacement of the degenerated muscle. Child is mentally retarded usually. Life expectancy is less than 20 years with death related to respiratory failure or cardiomyopathy. Towards sign. This is a confirmation sign clinically how to diagnose a muscular dystrophy. Evident by 6 years of age, child trying to get up from squatting position, turns to side, lifts his trunk by supporting his weight on his arm and then stands up supporting the body with his hands. This is pseudo-hypertrophy of calf muscle in Duchenne muscular dystrophy. This is the muscle belly is replaced by fat. Truer sign. How the patient is rising from squatting position to up. Look, initially supporting his trunk on the ground, and next holding his knee, pushing, using his legs and arms to get up off the ground. See, see again, still holding his weight on feet and then the hand as well. Only then he got in erect position. Diagnosis and treatment. The muscle enzyme, serum CPK, elevated up to 15 to 20,000, whereas normal is up to 2,000. EMG rarely necessary, but useful in doubtful cases. Histopathology of muscle show diffuse changes of degeneration and some degree of regeneration. Advanced genetic studies can find gene deletion. Physiotherapy exercises including walking and cycling are useful. Therapy may be required for contractures steroids for 10 days of each month to avoid chronic complications. Congenital myopathy, nemaline myopathy, myotubular centronuclear myopathy, central core disease, multi-mini core disease, congenital fibroside disproportion myopathy. These are as new to you as to me as well, but these are the entities you should have in mind while approaching a patient with neurological deficit or weakness due to muscular or neuromuscular junction disorder. Now, brief discussion of the myopathy. This is genetic autosomal recessive and dominant form. Was discovered in 1956 by Dr. Reyes. It occurs in 1 in 50,000 births, so very rare nemaline myopathy. There are 6 different mutations identified in this myopathy. Onset A occurs at infancy and early childhood. Clinical presentation A within the face, the neck, and proximal muscle weakness. There will be absolutely tender reflexes, normal creatine kinase, as there will not be muscle degeneration. Those CPK or MB or all those enzymes which will be elevated when there will be disruption of the muscle. Mytubular myopathy, a form of central nuclear myopathy, genetic X-linked recessive, autosomal recessive, and dominant forms are there onset at birth for X-linked recessive and infancy and childbirth for autosomal recessive type. Adult for autosomal dominant, X-linked is most common form and most severe. Clinical hypotonia respiratory pump failure and scapulocephaly is there. Scapulocephaly is actually really closer of the second structure of the skull. There will be elongated skull, anteroposterior in the skull of the baby will be elongated. This is called scapulocephaly. Mandibular disorder. The anterior posterior diameter of the skull is more or generalized cachectic appearance of the face. So next we ended up with this poor looking baby. Sorry guys, I could not listen to your questions because I would appreciate if you have any queries you should have asked me, but unfortunately we can't talk right now. For those who have some problem, they can contact me through telephone or through WhatsApp or through net, or they can come to particular days where we have or rota, though we are having only so COVID coverage, rest of normal OPDs and ward and ODs are closed. Those who are interested, they have any queries, they can contact, they can approach, they can ask anything. Thank you.